All right, everybody. In the interest of time, we're going to go ahead and get started. There's going to be more people trickling in here. I see them through the Zoom portal here. They're getting on. So we'll make sure they get in and get settled in, but we're going to go ahead and get started. So just as a reminder, we're using the chat feature like we have for our past sessions for introductions and CE purposes. Also, if you have any questions during the presentation or any tech issues you might have, please use the chat as well. I'll be monitoring them as we're going through. If you can use the raise hand feature as well, if you have a question at the end of the talk or anything like that, you can use that feature as well. But today we're going to have a presentation from Susie Mullins. I'm going to turn it over to her in a second here. And then if we've got time, we're going to have a little bit more of an expanded discussion into a case with Carolyn, who submitted that earlier today. So we'll have that on the docket. Again, any questions at any time, use that chat feature, raise that hand, and we will be on our way. So Susie, I will turn it over to you to share screen and your slides.
Okay, great. Thank you. And let me close a few things here. So before I share my screen, and I wanted to invite folks, if you had a scenario or a case study type question and just didn't get time to submit it, so we didn't get any submissions of case studies before the session today, which was a little bit curious to me because I would imagine that everybody probably come up with at least 2 or 3 with this particular subject matter. And you know, I think that even though we've been in a protracted addiction crisis in West Virginia for a couple of decades, that there's still, even within our profession, a lot of discomfort, a lot of uncertainty, perhaps some of our own biases and things that we need to lean into and look at. And for me, it's an equity issue. And so you might feel a little discomfort with some things that I'm going to ask folks to lean into today. I am in no way trying to be offensive or try to purposely make folks uncomfortable, but I think this is such a key, critical issue for the population that we work with, that if we're not comfortable working with this content, and if we're not comfortable working with helping people with these issues, that it's going to potentially cause harm to our students. So, I really invite folks to embrace the discomfort, and we'll work through that together. And if this is an area that folks feel like, you could really use some additional support in, I think that would be really helpful information and something that we could definitely figure out a way, I don't know, to do maybe a whole ECHO series around, working with SUD and recovery, but it's critically important, especially with our population. So I just wanted to put that out there from the get-go, because I am not intentionally trying to be cantankerous or confrontational, but it's just so critical, and it's more now than ever because of the overdose situation and the counterfeit medications and counterfeit pills and the contamination of the drug supply. We have, I have a lot of fear around things that students are ingesting, and they have no intention of overdosing. They have no intention of using opioids or anything that could kill them, but the risk is greater now more than ever. So we really have to be, on top of our game with our assessment and screening and things related to substance use. And with that, I'm just kind of wondering if folks could put in the chat what your current comfort level is with working with substance use disorder, or students that have substance use disorder, or are on the edge, maybe have a number of the symptoms, meet a number of criteria. Should have asked for that to be a poll question.
Getting some responses.
Okay.
Yep.
And then are folks aware of the additional credential that's available in West Virginia? So we have the West Virginia Certification Board for Addiction and Prevention Professionals. And so we have a couple of different credentials that are available. West Virginia does not have an addictions professionals license. All of our contiguous states do around us have licensure for addiction counselors, and that's something that we've looked at for a couple of decades, like 30 years here in West Virginia. We've made a couple of attempts at that, but that is an additional credential that is available in West Virginia. And then another source of information and education is WVCTSI, which is our Drug and Alcohol Counseling Association in West Virginia. The dues are very affordable, and a lot of benefits come with that as part. When you join WVCTSI, you also become a member of NADAC, and there are hundreds, literally hundreds of hours of free training on the NADAC website. Now, that training's available to anybody right now, but if you need CEs when you're a member, the continuing ed credits that go along with that are free to you as a member. So I'll give a shameless plug for both NADAC and WVCTSI as a member and board member of WVCTSI, and I'm also the regional vice president for NADAC for our Mid-Atlantic region, which covers seven states. All right, let me get in here and share my. Can you see my screen yet, Jay?
Not yet.
All right, 1 second.
There it comes. Yep.
All right.
You just have a couple of things covering it, just so you're aware. That's all.
Okay, let me see if I can make that go away, since you taught me how to do that. How's that?
Yep, and that one in the middle will go away here in a second. Yep.
Okay.
There you go.
And the when I was digging into some of the data for this, there are so many data points and sources of data that if you're like me, you got down into the rabbit hole, and I think you can find statistics to support anything if you look hard enough. So I just wanted to preface that with, the information I'm going to share with you comes from a multitude of sites, and I have where the data came from listed. So just a quick introduction. So a little bit about Collegiate Recovery. So we like to say that recovery is the expectation, not the exception, when people have a community and a supportive environment. And then this young man who, that's one of the beautiful things about Collegiate Recovery and working in higher ed, is that you get to see people's lives unfold, and you get to see them, graduate and get jobs and get married. And, I've just watched a fellow that I've known for a number of years go through his master's program, and SAMHSA sought him out. He's now over the harm reduction program at SAMHSA, and he is as we like to say, a product of Collegiate Recovery in North Carolina. So it's really, really a joy to watch people and their careers unfold, especially in recovery. And just quickly, I wanted to show you our team. So we have West Virginia State University, New River, Concord, Marshall, WVSOM, Bluefield, Southern West Virginia Community Technical College, and Bridge Valley. So we for the first time in our grant history, our project history, have a full staff. Here's our leadership and support team. And really what we are trying to do and promote is to see every student who is in recovery or seeking recovery have that support that they need at any institution in West Virginia. So we have a big goal of seeing this available everywhere and anywhere. We want recovery to be the norm in higher education. We have a lot of really wonderful champions and appreciate all the support from the Higher Ed Policy Commission. We have some really wonderful presidents, with this being Collegiate Recovery Week. Dr. Copenhaver at New River did a beautiful interview with with the peer staff there. So it's just been a delight in the last 7 years that this has been most of my career focus, and to see it grow has just been tremendous. Nationally, it is a growing movement. We've seen a lot of growth since 2012. There are a lot of positions open around the country in collegiate recovery. And for us in West Virginia, all of our programs from the beginning, from 2015, when Dr. Kathy Euro started the first one at WVU, very inclusive. So not just limited to substance use disorder recovery, but inclusive of mental health and behavioral health recovery, and inclusiveness for allies and people who are impacted by someone else's use. We have a couple of generations to come of students that will be coming to our schools who have been impacted by parental and other family member substance use. We have, more people in foster care than kids in foster care than we've ever had. And, as these students age into out of foster care and into higher education, we are going to be seeing those students. So it's important that we also have programs to support them. This is the list of alliance partners and collaborators. The Alliance for the Economic Development of Southern West Virginia is where I'm housed, and that's a program at Marshall University Research Corporation. So the schools you see listed here are the member institutions of the Alliance. University of Charleston is our newest, and then 2 of the schools do not receive funding through our grant. So Mount West, they have Collegiate Recovery just getting started, but they found funding from another source. And for WVU Tech, they have a state grant through the Office of Drug Control Policy. And then a number of the schools that are in white are the schools that have peer support specialists that are funded through our grant. And then we collaborate with WVU, with Eastern, WVU Parkersburg, and we want to collaborate and support and provide technical assistance to any school in the state that's interested in starting and growing recovery support services. So this is just a quick picture. And so we'll move into a few things, and I know that some of you might be members of the College Counseling Center Directors Organization. When I went looking for data and looked at their most recent survey, I was really shocked to see the presenting concerns list and the glaring absence of substance use disorder. Almost everything else is listed there, but substance use disorder is not. Now, not being a counseling center director anymore and not having taken this survey, I'm at a bit of a disadvantage. So I don't know if the question just isn't asked, if that's something, I'm very strong in advocacy, and I think that if the question isn't being asked on this survey anywhere, then we need to advocate for this question about substance use and substance use disorder being included in the list of questions. So if anyone has taken the survey and knows why that's absent, I'm definitely interested in knowing why that's absent. However, if you look at the list of things and the responses, 61% of the presenting problems are anxiety, followed by stress, followed by depression, followed by family concerns, academic performance, relationship problems, trauma, sleep disturbance, eating and body image concerns, grief and loss, and suicidal thoughts. All of those have some relationship to the use of substances, and that doesn't even have to mean that the person reaches the threshold of being able to be diagnosed with a substance use disorder. I'm going to be doing a whole other session next week for WVCTSI on alcohol, society, and women. So if you're interested in that, I can send Carolyn the link. But we know that even if people don't reach the threshold of being diagnosed with a substance use disorder, that substances play a role in many of these other conditions. So what does research say about why people use substances? Curiosity, to fit in, to feel good, to feel better, and to do better. And, when I first saw this in another presentation, I thought that it was a really great classification system when you think about, asking people why they use substances, or when we see students in our counseling centers, what is the need that they're trying to meet by the use of the substance is an important question, for us and for them to think about. So, these are very simple, non-clinical-ish terms that you might want to think about. So any initial reactions, input of why substance use might not have been included in that survey, or does that stand out as being peculiar to anyone else? And of course, I can't see anybody, and I'm not seeing the chat, so.
Feel free to, use the chat or unmute or raise your hand if you want to make a comment. Susie, we did have a question about signing up for NAADAC and WVCTSI. So Carolyn put that in the chat. Let's see. I wonder if the survey asks symptoms as opposed to diagnosis, and it does seem like a glaring omission.
Yeah, I was really shocked, because, this population, this is one of the key issues for our population. All right, I'm going to, hopefully this is going to work, Adam.
You are going to have to share your other screen. So stop share of that. Yeah.
All right.
But it was working. The volume, it was coming through. So.
Okay.
Yep.
Oops. Sorry. Can you see that yet or not?
Not yet.
Okay. 1 second. I wish there was a less wonky way for this.
Future updates. That's all we can hope for. When they keep updating it, it gets better. There we go.
Okay. And I like to show this because it's very short and it is very understandable. So when you're trying to explain this to other people, such as parents, because, having worked at a couple of counseling centers in my career, we're also, because of CFR 42, Part 2, and on top of HIPAA, sharing information that has to do with substance use with families is very tricky. It's not something that we can do without explicit consent, but a lot of families do not understand what is happening with their students.
Addiction, also called a substance use disorder. Over 21 million people nationwide suffer from addiction, and 1 in 7 people will experience addiction at some point in their life. Recent increases in the use of opioids have compounded the problem. Each day, we lose 174 people to drug overdoses, and that number climbs to 415 if you factor in alcohol-related deaths. Scientists first began to understand addiction as a brain disorder in the 1950s. Doctors Olds and Milner, in laboratory studies of rats, found the parts of the brain affected by addiction. But then, in 1994, doctors Volkoff and Schelbert, top neuroscientists, ran PET scans of the brain that showed the effects of substance use disorders. Like other diseases, these scans showed it affected tissue function. There are 2 main parts of the brain affected by drug use: the limbic system and the cortex. The limbic system, located deep within the brain, is responsible for our basic survival instincts. So when you do essential things to stay alive, like eat, drink, find shelter, have sex, or care for your young, your brain reinforces behaviors that cause the release of dopamine from this region. That reward for surviving is also transmitted to the amygdala and hippocampus, which records a memory of that feeling, so we seek it again. This is our survival hardwiring. Addiction also affects this area up here, in the prefrontal cortex, which is what separates us from other animals. This is where decision-making and impulse control live. When drugs or alcohol are used, they activate the same dopamine process in the survival center, and when use is repeated, that substance can hijack that part of the brain. This hijacker changes the brain and weakens this system to make it believe that the primary need for survival is the drug. In hijacking the brain, it can usurp those primary motivations: food, water, shelter, sex, and protecting our young. And the hijacker needs more and more of the substance to activate the same level of reward or feeling of pleasure, causing the brain tissue to become increasingly damaged with continued drug use. So why don't all people who use alcohol or drugs become addicted? There are factors that contribute to the development of a substance use disorder, including individual factors, like genes and age of exposure, and then environmental factors, like drug availability. But there is good news. Addiction is preventable. The key factors that aid in preventing addiction can be categorized into two parts: risk factors and protective factors. Protective factors range from parental involvement, programs that improve self-control, limiting availability, and increasing attachment to your community. Another key element in preventing substance use disorders is to delay when use begins. Put simply, prevention is about delaying the onset of first use. In the adolescent brain, where brain tissue is more vulnerable, the hijacker is more prone to weaken the brain and plant itself as a disease. Those with substance use disorders commonly initiate first use much earlier, between 12 and 18 years old, which increases the likelihood of the hijacker taking hold. But if the hijacker takes hold, addiction is treatable. Advancements have been made in assessments, detox, treatment programs, recovery supports, and medications to treat addiction. Brain scans show that once in recovery, the tissue in the limbic system and cortex can get better. With your help, we can expand these innovations to help millions of individuals and families and ensure that addiction is treated as the medical issue that it is. Together, we can solve this. Join us.
So I hope that and I can send that link to Carolyn as well. I hope that might be a helpful short video if you have folks that need help understanding, because a lot of folks still don't understand because a lot of the consequences of substance use disorder just don't make sense to a lot of folks. And until you understand the brain involvement, the behavior doesn't make a lot of sense. All right, 1 second. Let me get back to. Are you seeing that, Jay?
Yeah, you just you're not in presentation mode yet, but yes.
Okay. Let me get rid of this bar. Hold
Yep.
on. All right. So screening, assessment, and diagnosis. What does the DSM say that we have to do before we make any diagnosis? Before we diagnose anxiety, depression, just about anything, we have to make sure that the symptoms are not related to substance use. And how do we do that? Obviously, we assess for substance use. And so if we're not assessing properly, we might be missing diagnoses, we might be misdiagnosing. And I know in the college setting, the diagnosis is not as critical as it is in an outpatient or community-based setting where things are tied to billing. But still, if we don't know what we're dealing with, then we don't know what the treatment plan is. So if we're not assessing properly, if we're not assessing frequently, we're going to miss these things, because very similar to trauma and other conditions, and suicide, a lot of times folks are not going to tell us at the first session what's really going on. The first 2 or 3 sessions are really, rapport building, relationship building. They're trying to figure out whether they can trust us and, things of that nature. So we really have to be assessing early and often and ongoing, because as that trust builds, we're going to get more and more coming out. And so if we do at intake, which, a lot of us, this is how we operate, we do an initial assessment or initial screening, and if nothing is flagged on that initial screening, a lot of times we never go back and ask again, and then scratch our heads about, well, why are things not getting better, or why are these things continuing? And not that substances underlie all of these conditions, but we can't properly tell what's going on if we don't know about the substance use, because we know, alcohol and other things impact sleep, they impact appetite, they impact anxiety levels, depression, ADHD symptoms, and we can't properly diagnose and assess those things if we don't know everything that's happening. So, one of my questions is, what tools are you using? What resources do you need to be better prepared to assess? Because, we need to have the proper tools. And if you don't have those tools, is that something that that either WVCIA or the Higher Ed Policy Commission or Bureau for Behavioral Health, how can we better equip everybody to have the proper tools to do your job? So it needs to be more than the cage. It needs to be more than 3 or 4 screening items, and a couple of the resources that, and I'm not sure what everybody's using, but Screen U has a couple of different options, and they also have a prescription drug screening part of Screen U, which is really important. The audit, the QDIT, the e-checkup to go. College AIM is a really good resource to look into, to get more information about individual strategies and environmental strategies. So that's the other thing to think about, is that, how are we addressing this? We have to address it on the individual level, and we also have to address it on the environmental level, and those things work together. Same thing with the whole continuum. We want to be working in lockstep with our prevention, and some of you, as I was, were the one-stop shop. You're charged with doing the prevention, the sexual assault prevention, the suicide prevention, and the early intervention and the treatment. So I recognize that it is a lot, but some of these tools might be able to make things a bit more manageable. So I'm not going to go into, partially because the interest of time, but the diagnostic criteria and understanding SUD from the DSM, the diagnostic criteria, and then, we now, instead of it being dependence, it's mild, moderate, or severe substance use disorder. So now what? Treatment really has to be integrated, and I don't know if this is still happening or not, but in the older times, if someone came in for mental health and things were more substance related, they got shifted out another door, and we really have to have no wrong door policies, and we need to be able to treat at the right intensity for the right duration. And something else that I really encourage folks, if you're not familiar with, is ASAM, the American Society of Addiction Medicine, and that assessment is 6 dimensions, and we really need to look at all of those dimensions when it comes to substance use disorder and the proper level of care. And we have to provide care. To say that it's outside of our scope, we don't treat substance use disorders with this population, in my opinion, it's just not acceptable. We have to expand our scope of practice and become proficient in treating this, especially with this population, because many times they don't have anywhere else to go. They don't, they're reluctant to use their parents' insurance. And for a lot of communities, there's not a great place to refer them. So to me, it really comes down to an equity issue. And, we can't defer that responsibility to someone else, because there might not be someone else to even defer that responsibility to. So, we would, if we saw a high rate of anxiety disorders, if we saw a high rate of depressive disorders, we would, take that upon ourselves to learn how to treat that condition. And, with our population, it's a high probability that substances are going to be a factor. And if we're a training site, if we have students that we're training at the master's and above levels, this is where the new providers are learning how to provide care. And so if we aren't setting the example and we're not incorporating substance use disorder, those patients aren't going to get the care, and those students aren't going to get the care that they need. So what do we need to do to help everyone build that capacity? How do we support people getting that additional education and training and clinical supervision to work with these issues? So just briefly, the 6 dimensions of the multidimensional assessment: acute intoxication or withdrawal potential. And, this is a risk management issue for schools, because if you've got somebody who is in acute intoxication or withdrawal and they go back to a dorm room, that's not going to end well. And it's also going to push those issues out into other areas on campus, like residence life. So dimension 2 is biomedical conditions and complications. With young people, this isn't going to probably be as much of an issue, but it could be, especially in terms of diabetes and blood sugar type issues. And then emotional, behavioral, and cognitive conditions and complications. Readiness to change. This is where I know all of you are probably very proficient in motivational interviewing and stages of change. And so that this is very informed by readiness to change, and what are folks willing to change, and where are they in recognizing where they are in that process. Relapse, continued use, and continued problem potential. And then the recovery and living environment. So what is their situation? Are they going back into a dorm or back into a sorority house or fraternity house where, that is a recovery or abstinence hostile environment? So all of these dimensions, and there's days and days of training that could be done around ASAM and the placement and dimensions that need to be assessed. But in case folks have not heard of that before, I just wanted to introduce it, because it is a really nice framework to use in doing our assessments. So we know that there are lots of things that go into substance use disorder in terms of past experiences with trauma, past experiences with their home environments and where they come from, and parental use and attitudes, what their own exposure has been to substances and early use of substances. The longer we can delay first use, the better that is. And not everyone that uses in college, and college is a different kind of world for a lot of people. A lot of things become acceptable in that 18 to 22-year-old experience in college that, if these students were in the community, these behaviors would not be as accepted. And, so that's part of what makes it difficult and challenging for students to recognize problems with their own use or high risk use, is because when they're surrounded by people who are doing the same thing, they don't stand out. They don't think that it's that unusual. So that's another reason for us to screen and assess early and often. You all have probably seen this in terms of low risk drinking, high risk drinking. And, we know from social norming campaigns and from assessments that, the vast majority of students, if they do drink, they aren't doing so in a high risk fashion. But for those that are in the risky, harmful, and severe use range, they're really in danger. And this information is based on adults, and there's no data on what safe use is for adolescents. And, even though these folks are over 18, they're still adolescents. We know that brain development is still critical at this period. So, briefly, the typical addiction career, and, again, folks, everyone that uses and even uses heavily in college doesn't go on to develop a substance use disorder. However, when you talk to folks who have a substance use disorder who have been in college, when you ask them to go back and think about when their addiction career got out of control, frequently it is during college. So this is from a 2014 Alexandra Laude study, and so age of first drink, 13 years, 8 months. First drug, 15 years, 2 months. There is a cycle of addiction-related consequences that happens, and a lot of times folks don't get treatment until they're in their early 30s. And then there is a lot of times a cycle of a return to use and recovery cycle, so they're in and out of recovery. That goes for another 10 years. And so a lot of times people don't get into stable recovery until they're, in their early 40s. And so what that comes out to is a loss to the individual of 16 years of active use and about 10 years of that cycling. So, when you think about that, how critical that period of life is in terms of your education and establishing a career and a family, these are critical periods.
Hey,
So,
Susie, I just
yes.
wanted to give you the 5-minute warning like we discussed. We're at 12:40, so give you a 5-minute warning.
Okay. Oh man, this is going to be rough. I think we need part 2. So 2019 High School Behavior Risk Survey. This is West Virginia data from the CDC. And I put this up here because I wanted folks to see these are the students that we have now on campus. And I will just draw your attention to the very bottom. So 11.7 had used prescription drugs not prescribed to them and not according to prescription, and 2.8% had used heroin, 2.7% had injected any substance, and this is West Virginia data. The 2018 Acha, this was alcohol use in the last 30 days, and cannabis use in the last 30 days, 14.2%. Some of the effects that were reported among drinkers from that 2018 data. So I've got the state and national comparisons, and we were pretty comparable to the national. So later regretted things, didn't know, had forgotten where they were, unprotected sex, considered suicide, had sex, someone had sex with them without consent, and the big difference between males and females here. The college prescription drug study through Ohio State University, I did want to highlight this because these are statistics about students who are using for non-medical reasons. So 9% use pain medication, 9.4 sedatives, 15.9 stimulants. So we are, seeing significant substance use. And these are some of the reasons. And it's interesting when you look at these reasons and you go back to that first, the study from the counseling center, and a lot of these things definitely overlap. So the core survey, we switched, WVCIA switched from the Acha to the core in 2020. Of course, that's during the pandemic, so there were some issues related to that. And then I put the comparison to the Acha 2018 here. Extent to which alcohol and illegal drug use changed in the last 12 months. So you can see that they're are some significant changes. Alcohol increased 14.8%, other drug use increased 5.3%. We'll skip over that part. And tagging on to what Paula Reimer had talked about with suicide prevention the last session, trauma, sexual assault, and suicide, which came first, the chicken or the egg? That's the age-old question. But we do know that there's a relationship with substance use and substance misuse. And so the more we focus on preventing substance misuse, we also will impact suicide prevention. This is some data from the Office of Drug Control Policy's data dashboard on fatal overdoses. And these are specific to ages 0 to 19 and then 20 to 29. So just in the period of time from 2015 to 2020, we had 61 deaths of people under the age of 19. I think that people don't think that there are young people dying of overdoses. Now, these are the suspected overdoses for the same age group, and these are emergency room suspected things that are seen in the emergency room that are suspected overdoses. And you look at that age group, 2,894 for the ages 0 to 19, and that's only for 3 years, 2019 to 2021. I mean, they're staggering numbers. We do all kinds of naloxone training, and within that training we talk about signs and symptoms of an opioid overdose. I do want to scroll down here really quickly, and we don't have time to talk about recovery and recovery language and stigma, but something I do want to show you. So many of you know about our Nalox Box initiative, and those 50 Nalox boxes are being installed. These are the schools where we have delivered or are scheduled to deliver them, and then we have a West Virginia created product through the West Virginia Drug Intervention Institute. This is the one box. This is a smaller box, and it is technology enabled. So when you open the box, the screen pops up to a video of Jan Rader walking you through how to administer naloxone. It has a training mode, it's closed caption, and it has a Spanish option. So these are ones that we are also rolling out. And so I'll stop there in the interest of time so that we have a little bit of discussion time, but I'm more than glad to continue this conversation in the future if that would be helpful or of interest to folks on the call.
Thanks, Susie. Yeah, sorry to cut you off. It's always an awkward moment, but a lot of information. You're right. Too much for one session, has to be more. But thank you so much. Again, we'll pass out the slides as the recap, so you will have access to them with the links to the videos and all those things. So hopefully that'll help you guys after the session. But yeah, we'll open it up for questions. I know we have a case kind of scenario that Carolyn was going to bring up. We could also do that, but first wanted to open the floor up for any follow-up questions for Susie. Shameless plug, Susie. So we do have an SUD echo right now that is for adults and young people, but it's not campus focused. It's just all around focus. And one of the things that we've noticed about when we get people into treatment is that the hook usually is taking care of something very minor or something that can't actually be taken care of for them because they don't have just SUD or, So like, for instance, we've had people that get their hepatitis C cured. You take a pill for 8 weeks and that's a win. And all of a sudden they feel like they can do something about other issues that they have in their life. One person, we had them get glasses. They needed new glasses. So we worked on getting them glasses and they just felt better about themselves, that they could go and make a positive change. So it can just be even doing little things like that to get the ball rolling. We've noticed. So I just thought I'd mention that.
Dental, jobs, and for folks that aren't familiar with Jobs and Hope, it's a tremendous program. It is available, originally designed for people in recovery, but it's open to anybody, and they have a lot of benefits associated with their program. Not sure how many college students really have taken part in that, but we work with them closely because there are a lot of folks who have been in college and had to stop their college and educational goals because of their substance use disorder, and would then return to campus.
Susie, we had a question in the chat earlier asking about if a school is not already involved in the Collegiate Recovery Network, what would they do if they were interested in taking next steps there?
Just shoot me an email and I will be more than glad to set up a time to talk about what the options are and how you might get that started on your campus, and what that looks like. Is it a grassroots student driven, which is what's happening at WVU Parkersburg? Is it seeking outside grant funds like Mount West did? They got creative and partnered with the RCBI in Huntington and were able to get some grant funds to hire a peer support specialist. So it can look different. The state from time to time has collegiate recovery grants. Because of COVID and the impact of COVID, they haven't put out anything new around that. But one of the things that I hope that we can advocate for at the federal level is the 10% recovery set aside. And if we got that 10% recovery set aside, that would bring a lot of funds that could be tapped into for all sorts of recovery support services. Do you want to talk about your scenario, Carolyn?
Susie, we did get in the chat for your email address. If you don't mind sharing that in the chat while maybe Carolyn goes over the, yeah, perfect.
Sorry, that's EDU, not
Sure.
EY.
For anybody that doesn't know me, I'm Carolyn Canini and I work for Higher Education Policy Commission. I don't work currently on a campus, and so this scenario that I wanted to bring up for discussion isn't something that I've experienced directly with a student that I'm serving. It's something that I've heard more so from within meetings that I've been in, and that's both within the recovery meetings, people serving the recovery community, as well as educational meetings. So the scenario is related to students in recovery. A student in recovery might be interested in a career where they help others. So they enroll in a social work or other human service field or health sciences field that requires a field experience, a license to practice upon graduation. However, the student might be unable to pass a background check required for their field placement location or their employment location, or possibly even for to obtain a license due to some prior justice involvement that they had while they were using it. So my question is for the people on the call, have you ever encountered this with a student who was enrolled in a program, maybe even getting close to completion of a program, and had difficulty developing getting a field placement, or had difficulty getting employment? And if so, what resources did you explore to help this student? And are there any things that schools can do to support students who have past justice involvement? And then I have a final question there too. Are there any systems issues that contribute to work barriers for these students with justice involvement? So a lot of questions. I'm interested if anybody has experienced this with students they serve.
We have a comment in the chat from Cynthia Workman. Is expungement an option?
Yes, expungement is an option. It takes a lot of work on the part of the individual. And Chelsea Carter, I think she was the first one to get her social work license. And forgive me because I cannot remember. I can't remember if she had to get a pardon from the governor. I know that the governor was involved, Booth Goodwin was involved. There were some changes at the board level that allowed her to get her license. So it really is situation dependent. Legal aid can be a great resource. One of the biggest ones that we see is for people that have past child protective services cases. And the part of that is related to the West Virginia CARES background check to work for a behavioral health center. And there's a separate child protective service, adult protective service check that has to be done. And that has been tremendously challenging, that people can't, and it's applied very across the board. Some places will hire and some places won't, and some places will hire, and then if the CPS comes back that there was a CPS case, then they let them go. So there are definitely some systems issues that need to be addressed. But I'm curious if folks have successfully navigated any of that with any of their students. And Margaret has her hand up.
Yeah, I'll keep this brief because it's not unfortunately an answer to those questions or what you just posed, Susie. It's actually just that I do present this though when I do my prevention programming as kind of just a strong recommendation to the students if they're thinking about choice making and thinking about their alcohol use or substance use, to think about if they are planning to pursue a career in this way, that this could then deter them or be a barrier to them being able to serve in those positions later down the road. So I don't know if that's helpful, but it is something that I present in my prevention programs that I do with like first year students about alcohol prevention, et cetera.
And Dr. Persley has something in the chat there. And, we have actually had really a lot of luck with felonies. We have a number of folks that have previous felonies, and we have had really not as much of an issue with getting people a variance. So the West Virginia CARES will issue variances. We had a fellow that was still on parole that we hired. He hadn't been out of incarceration, but maybe 4 or 5 months, and had multiple felony histories. But they weren't federal, they weren't drug charges that happened while he was receiving student financial aid. So that's another thing that is often misrepresented to people, that if they have prior felonies, they can't get federal student aid. And, other than if they had a drug conviction while they were receiving federal student aid, we haven't seen a whole lot of barriers around that too. So I think, we have some work to do around helping people understand the myths versus the realities. And then, what are the workarounds? Are there, things that you can do, like a strong variance and multiple personal character references and references from your probation and parole officers and things like that. So, we've been very fortunate, and it kind of does make you scratch your head, and not that anyone's supporting child abuse or elder abuse or adult abuse or abuse of any sort, but if your job has nothing to do with that, why should you continue to be punished the rest of your life for something that has nothing to do with your job, and for which you've paid your debt to society and reestablished relationships with your kids and all that sort of stuff. So it is the unfortunate punishment that keeps punishing for a lot of people.
There's time for one final comment, and then we'll do a couple of housekeeping items. Anybody have anything else to add?
I just wanted to say I appreciate Margaret's comment too. And I know a lot of the work that Susie does is to connect prevention with recovery, and to show that, for one, recovery is prevention, but also that the two systems and the work of both go hand in hand. So just appreciate, Margaret, you piping up about sharing consequences that could happen with students.
Yeah, and having recovery-informed prevention is something that I would really like to see us have infused a little bit more so that, recovery and prevention are working together. Our folks work really closely with Heather Stoniker, McDonald Stoniker's grant at Marshall as well. They work with the same schools that we work with, and Concord University has the first student org that is both prevention and recovery, which is exciting, and we hope to see happen more. That we really work more hand in hand together as opposed to seeing very distinct parts of the continuum of care.
Thank you again to Carolyn and Susie. We're gonna go ahead and wrap it up for today. Just a reminder, we have our makeup session is the 26th, so in a couple weeks here. You're going to be getting an email from CTSI Zoom. It's going to confirm the link. It's going to be the same link you've been using all the time for the past sessions, but it's just going to send you a reminder because it is a change in the schedule. So just a heads up on that. Be on the lookout for that email. And you also get the recap email with all the information that was spoke about today, as well as all the links that have been in the chat. So thank you for everybody attending. Thanks again to Susie for your presentation and Carolyn for the scenario. And we'll see everybody in a couple of weeks for our final session. Hard to believe. Final session. All right.
Thank you, Carolyn. Thank
Take
you,
care,
Jay.
everybody.
Thanks, Susie.
You got it.